morning. It's a real pleasure to be with a low-carb community, even remotely. And I really have to thank all of you, particularly Jeffrey, for putting on this great meeting. And I also apologize for being late into the low-carb community gang. I've been doing low-carb since the 90s, but my orientation has been a little bit more towards coronary calcium and advanced lipid testing as far as research, particularly since Khurram Nasser joined me about 10, 15 years ago. But I think it's so important that we integrate imaging and advanced blood testing with low carb. It's becoming so big and so important. And so far, both Ivor and Jeffrey have done a great job of starting off with coronary calcium, as well as another test that we've been doing the past years, the past really year, the Kraft test. So I'm going to really talk to you about my experience, which is now over 30 years, in using coronary calcium imaging on a daily basis to make decisions for my patients. And here is a three-dimensional reconstruction of the three coronary arteries and calcium. And what we've learned is that calcium always begins in the high LAD. It's not a widowmaker. And you see the largest plaques here because they're the oldest plaques. And as atherosclerosis progresses down the artery, and we're going to describe why this occurs, the younger lesions are smaller. And in fact, we can tell the total plaque burden and really the age of the lesions and the age of exposure to risk factors. And that's what we're going to talk about today. Now, the traditional national guidelines, where I started and we all started, was just doing a one-time measurement, say somebody who's 50, of their traditional risk factors, and then making a 10-year prediction. With this, we did not account for all the prior 50 years and what was going on. And we know atherosclerosis, for somebody who has it at age 50, didn't start there. It started a long time ago. So we really have not accounted for this risk factor exposure. It was many years ago when Dick Devereaux published this concept that while we start with risk factors, again, the one-time measurements, we're trying to prevent morbid events, and invariably we go through this period of preclinical disease. And in particular, we're talking about coronary calcium, but there are there's other preclinical disease such as left ventricular hypertrophy, and invariable, the preclinical disease was much better predictors of morbid events than the conventional risk factors. And the other thing we've learned is it was certainly the conventional risk factors were not all the risk factors. There are so many more. And for some reason, in the original Framingham risk factors, they left out family history, which we all know is important. And really what we've learned today is that family history of diabetes, or really insulin resistance, leads to increased insulin secretion, which we measure today, we didn't back then. The insulin secretion caused fat to be accumulated in the liver and really spills over around the liver into the bloodstream, and eventually is the major cause of coronary artery disease in the country. Now, it also eventually leads to diabetes, though not so early, as I think you've already heard at this meeting. Now, it is the insulin secretion that we realize now is the cause of high blood pressure from blocking nitric oxide and from salt retention and obesity. And in fact, total cholesterol is frankly useless. So our concept of the basic risk factors and targets of therapy have really changed a great deal. This is our current approach. Now, atherosclerosis really indicates certainly risk for coronary disease, but as we know now, it's all-cause mortality and really all chronic disease. Cancer, Alzheimer's, just almost all of what has made the Western world ill. And it turns out what's important is the total amount, or what we call the plaque burden, of arteriosclerosis. And that's reflected by the coronary calcium and the coronary calcium score. Now, the main cause of coronary calcium is lifestyle, and it's diabetes, but before we ever develop diabetes, it's prediabetes and what I would call pre-prediabetes. And again, it starts with insulin resistance, particularly from the change of the Western diet, as well as genetic predispositions. And the high insulin turns the sugar content and the bad carb content into fat in our liver. The fat overflows to obesity, mainly visceral obesity, and the fat also overflows from the liver into the bloodstream, increasing triglycerides, eventually decreasing HDL, and causing small LDL and HDL particles, which cause atherosclerosis. And because of the salt retention blocking nitric oxide, we also have high blood pressure. The interesting thing that I've learned relatively recently is this all occurs before we have abnormal oral glucose tolerance or hemoglobin A1C. So we're getting sick years before our blood sugar components, our blood sugar parameters are abnormal. And we know fitness, sedentary behavior, sleep, tobacco, chronic stress all contribute to this. But it all starts many, many years before the blood sugars are abnormal. And then what's often ignored is we have a whole host of primary non-lifestyle genetic factors. And these that we measure routinely now, 9p21, which makes the lining of our vessels more porous to LDL particles, Lp(a), which is easily oxidized and can be atherogenic, though often alone it doesn't contribute a lot. There are probably 50 different types of Lp(a), and you really have to put it in the complete clinical picture. Familial hypercholesterolemia can certainly cause high plaque burden, but not everybody with a cholesterol over 300 has it. There are many unknown causes still, although what we found is there aren't too many patients where we don't have a clue what's going on. Something else that's much more common than we thought before is HDL dysfunction. A lot of patients, particularly where there's a family history of heart disease and particularly high HDL, the HDL is dysfunctional. And we can measure it, and it's a really important contributor to plaque burden. And small LDL without the atherogenic lipid profile, that's just genetic small LDL, we realize is also important. So we see patients with a lot of plaque who are not pre-diabetic or pre-diabetic, but they have small LDL. And when there's family history, it can become important through either side. Family history of type 2 diabetes, and one important point here is often we ask for a family history. Is there diabetes in the family? The answer is no. Say the father died in his 60s of a heart attack, was not told of diabetes. I always ask, did he have a belly? Well, maybe a little. Did it increase as he got older? Yes. That is the gene, even though they were never told of diabetes. And of course, familial and genetic factors is very important in this side. In this side, we don't know that lifestyle can change any of these primarily genetic risk factors. And here's an example of a patient we saw pretty recently, a 67-year-old who had a lot of plaque, but his baseline numbers were not impressive. So here he is with this belly. On the calcium score, we can see below the diaphragm. So here's liver, spleen, and all this is visceral fat. And with this visceral fat, his baseline total cholesterol, LDL, triglycerides, this was without treatment, were really unremarkable. And he actually saw a specialist who told him everything was fine. Well, he was sent to me by somebody who did, a referring doctor who did a calcium score, and it was 1200. And we did a Kraft test, and I know you've heard about this, by the baseline hemoglobin A1C was not in the pre-diabetic range. Close, but didn't make it, 5.6. So he had a very late and high peak of insulin, absolutely abnormal insulin secretion. And he had small LDL particles. So he had all these risk factors which were not apparent on the traditional risk factor Framingham algorithm. And here's the heavy calcium, and this calcium has been there for ages. You can tell because of the thickness. This didn't happen yesterday. Usually when you have this much plaque, it's been there a long time, and it's from not just a lifestyle, but something genetic. And in fact, he was homozygous for 9p21, a genetic factor that makes the vessels more porous. So he was really at high risk, not recognized on conventional testing. So here he is, 9p21 homozygous, allowing small LDL particles to filter into the vessel wall. And he had abnormal insulin secretion, fatty liver. He had all these risk factors, but he hadn't reached an abnormal glucose. So how do we make early diagnosis of preclinical disease before you're symptomatic? And I'd like to talk a little bit about the strength of association. I saw this slide from Bill Castelli back in the 80s from Framingham, and it was clear that those in Framingham who had no coronary disease versus those who did had essentially the same average cholesterol. It did not differentiate in individuals, slightly in a population. When we look from the MESA study at calcium scores in those with 0 versus any level, these are not the type of small increase in percentages we see in population and observational studies. These are 3, 5, 10 times the risk when calcium is present, and depending on how high the score is. And when you just do one measurement, again, you're not taking account for the unaccounted risk factor exposures. So here's LDL. It could be all over the place. And that could be causing a lot of plaque or little plaque. And how does that contribute to how much plaque you have here and what your real risk is? Well, here's a study actually from Framingham. And what it shows is the duration of risk factor exposure is important. And this is many years of high lipids and bad lipids, and this is fewer years. And this is the incidence of coronary artery disease. So the dose of risk factors is really, really important. So what's happening here is an integration of many risk factors, but and when we're interested in the risk factors, what we want to know is how this is going to affect us if we're 40, 50 over a lifetime, not just over the next 10 years. And what's going to happen if we change our risk factors? Well, I'm going to argue it's a calcium score that integrates all this information and tells us really when the risk factor exposure started, how long there's been exposure, and how is it affecting us lately. So coronary artery calcium, first, it quantifies the total plaque burden. Atherosclerotic plaque, it's fat, it's calcium, it's scar tissue, but the amount of coronary calcium reflected in the calcium score reflects the total plaque burden. And it also indicates the age of individual plaques, as we're going to see. It reflects the activity of atherosclerosis, past and present. And the size, density, and shape of calcified plaques indicate the exposure time of various risk factors. Often, all this information from the calcium score is not being used. So, when Dr. Janowitz and I first started with the calcium score back in the late 80s, the hypothesis we knew arteriosclerosis caused coronary disease, big surprise there. We also knew that clinical coronary artery disease was associated with a large plaque burden. Dr. Bill Roberts and others in pathology studies showed this. You don't have a heart attack with your first plaque. The more the plaque burden, the greater the chance of having coronary disease. The calcium score reflects total plaque burden, and Dr. Rumberger and others at the Mayo Clinic taught us this a long time ago. And the coronary calcium score has been demonstrated to be superior to any algorithm of risk factors because it really integrates all the risk factors together. So why? Well, one thing I want to introduce is the feed-forward concept of coronary plaque progression. And we're going to start with a cross-section of a plaque with what I call a cholesterol pimple. And this is my artwork of the normal lumen and a cholesterol-filled plaque. So we start with a pristine lumen. And what we know now is the early plaque, unlike what I was taught during my training, doesn't grow into the lumen, it grows out and we get remodeling. So if you're just looking at an angiogram, you're not going to see a lot of what's happening in the vessel wall. Now, the natural history of individual plaques is when that cholesterol pimple gets to be a certain size and there's inflammation, other factors, it pops, exposing tissue to the bloodstream. And that causes a blood clot, just like it does with damage in vessels anyplace else in your body. But 99 out of 100 times, this does not occlude a vessel and cause a myocardial infarction. It heals over. And it may heal over completely in the vessel wall. It may heal over with a little impingement on the lumen, or even 70-80% in the lumen. And the thing is, it's healed over with scar tissue and calcium. And what it is, once this happens, it becomes inert. It doesn't progress. And most single vessel, 70, 80, 90% lesions don't cause symptoms. If they did, everybody would present with one vessel disease. So what about the age of plaque? And which indicates the duration of risk factor exposure. Well, here's a CT angiogram of a soft cholesterol-filled pimple plaque. Once it ruptures or degenerates, you start to get a denser scar tissue and you get coronary calcium. And over the years, the area of the scar becomes more calcified, but the calcification doesn't impinge on the lumen. It will not affect an angiogram. So here we are, soon after a plaque rupture, scar tissue first, And over time, in about 6 months to 2 years, you see calcification. The blood flow stays the same. The lumen doesn't change. And so the size of the plaque continues. So this may be 1 to 2 years, 5 years, 20 years. And so when you look down a vessel, it turns out the calcification always begins near the beginning of the vessel and then proceeds down. So these are older plaques, like here. These are the younger, more recent plaques. And Dr. Cricky did a study where he looked at quartiles of plaque density. And if you think that the less dense plaques are younger and indicate more active disease, then they may be higher risk, indicate overall higher risk. And in fact, they do. So here is the densest plaque, and those are the least risk of a future myocardial infarction. Here are the younger, less dense plaques, and those are the ones that have the relatively highest risk. So this is consistent with it, which is really logical, that if you have active disease where you're still making new plaques, they'll be less dense and a higher risk. And in fact, if you have a risk factor such as late onset diabetes, in this case somebody in their 50s, and you just start laying down plaque because of just the risk associated with diabetes, you have a lot of small, young plaques. And so even though your total plaque burden may not be so high, these are all active because of this new risk factors that you've developed relatively late in life. Now, what about if you've had risk factors that are genetic, such as high Lp(a) or 9p21? You've had exposure your whole life. And this is another 58-year-old, but old plaque. So this plaque has been around for a long time, indicating a long duration of risk factor exposure and overall higher risk, as we'll see, if it's untreated. Now, coronary plaque progression depends on many factors. One important one is the shear stress risk, and we'll look at that first. This is the Colorado River, and here's the water flowing. When it's on the inside, it flows slower than the water on the outside. It's just like with horse racing. If you hug the rail, the poor horse on the outside has to run that much faster to keep up. Well, it turns out here's when it bends the other way. Well, sorry. So here where the water is going slower, that's where you deposit silt. Where the water is flowing faster, you carve a canyon into the mountain. And here's the flow going around in the other direction. And in fact, here's where the silt is deposited. And here where is the canyon is carved. So the silt is just like cholesterol, as it turns out. So for those of you who are used to looking at carotid ultrasound, you know that it's on the inside of the flow where you develop the plaque, just like the silt on the inside of this curve in the Colorado River. And in fact, the blood pressure, the cholesterol level is the same where there's laminar flow in the common carotid and in the internal carotid here, but it's where there's turbulence and slow, low shear that you deposit cholesterol. And so what happens, here's laminar flow, here's the disturbed, slower shear, and this tends to cause a plaque here not here. So here's a new atherosclerotic plaque, and what that does, it causes this feed-forward phenomenon. The abnormal flow occurs further down the artery, so now this area is at risk for atherosclerosis. Here's a rabbit carotid where they looked at laminar flow, and here's laminar. Here around the curve is the disturbed flow. This is where we always see the plaque develop. Now, what about thrombogenic risk? If you just develop atherosclerosis, the coronary remodels, you won't have an event. So you need some thrombogenic risk. This is a rabbit arteriole, and here is a needle narrowing. This is without any treatment, just with a needle narrowing, causing that slow shear. Not only do you have risk of atherosclerosis, you have risk of platelet aggregation and thrombosis. And when you pull the needle back, you begin to disrupt the plaque and you get laminar normal flow again. So flow has a risk for thrombogenesis as well as atherogenesis. Now, what I also call vascular risk is important. And when you think of one of the first places you get atherosclerosis in your body, it's at the bifurcation of the aorta into the iliacs. These are often loaded with plaque, and the soft plaque, cholesterol-filled plaque grows. It ruptures. You get a clot, but you don't see people walking around grabbing their legs. Oh my God, I got the big one. And that's because the diameter of the vessel is large, the flow is robust, and the clot cannot be stable enough to acutely occlude the vessel. Well, it turns out in the coronary, it's similar. So we now know that in the proximal coronary, the atherosclerosis always starts here. We used to get worried with proximal calcifications, the widowmakers. These are not widowmakers. They don't cause events early on. And the reason is because the flow here is very robust, like the flow in the iliacs. So you always see calcification starting here, and it continues to calcify the scar tissue of the plaque, but it does not occlude the vessel. So here's how the feed-forward mechanism occurs. We're starting with a 35-year-old, first all laminar flow. But here's where you go around curves. You get more atherogenesis, just like in the carotid, and you develop plaque. Once you develop plaque here, then you disturb flow, and the disturbed flow feeds further down the vessel. And so soon you start with a plaque here, and again, disturbed flow, and I'm going to run through this a bit. You continue to make further down the vessel more atherogenic, and this is this feed-forward mechanism. And this is the natural history for those of us who follow people with coronary calcium over the years. It always begins proximally and progresses distally. And we've always known this about atherosclerosis. Now, as you get further down and the vessel narrows, and the amount of calcium also makes the vessel stiff. So early on, if you rupture a plaque proximally, the vessel's bigger and it can dilate. Once you have diffuse calcification, a very high plaque burden, and a stiff vessel, that's where you can no longer dilate the vessel, and the vessel is narrow. So here we have disturbed flow all the way down the vessel, which is atherogenic and thrombogenic. So you have thrombogenic blood, and the vessel is narrow, stiff. Now you have a vulnerable vessel. And this is where you get your your occlusion. So this explains why there's invariably a high plaque burden before we have an event. Now, there are exceptions. Some people are very thrombogenic, particularly smokers. And sometimes in families, there's particular thrombogenic risk. But in general, the more lumpy, bumpy your vessel is, the more disturbed the flow, and the higher the risk. And this is a study from the very famous Heinz-Nixdorf study, where they followed a large population, and including serial coronary calcium scores. And it turns out those who started with more plaque, a lumpy, bumpy, abnormal flow, had faster progression. Those who started with less plaque, less lumpy, bumpy, more laminar, not as atherogenic or thrombogenic, they had slower progression. So this really supports the hypothesis. Now, what about when we treat? Do we interrupt? This is a patient who had long lifetime exposure of dyslipidemia and homozygous for 9p21. Long exposure. This is before any treatment. So a lot of old plaques. But as you go down the vessel, also smaller, younger plaques. This is the natural history. Well, what if you intervene here with effective therapy? Diet, statins, other targets of therapy. Then you stop having soft plaques growing and the progression stops. Is this what we see? Well, this is a patient study who I followed for close to 30 years. Wonderful lipids the whole time. He had multiple risk factors, very high calcium score, but this is a relatively recent CT angiogram, and this was the calcium that calcified plaques when we started. And we started treating aggressively, very good control. The old plaque continued to get larger, more dense. They became obviously older plaques, but no new plaques. And this is what we see consistently when we treat aggressively. If we don't, it means we're doing something wrong. If we see new, younger plaques going down the vessel. And so here's a 3D reconstruction of another patient followed for over 20 years. Here is the old dense plaque, and here is where all of a sudden we're not seeing any new plaques tracking down the vessel. And here on the other side, again, old dense plaque, but no new plaques. And here's somebody, the plaques are particularly easy to follow when you don't have a large plaque burden. So here's a 53-year-old who we've been following for close to 10 years. He has had 2 lesions in his LAD. He's been treated with lifestyle and medication. And we see the same plaques year after year, but no new plaques. So both we and the patient can have confidence that we're doing a pretty good job. Now, the plaques do get bigger and denser over time, but we don't see new plaques. Now, what if there are new plaques forming? Again, the early plaque will be a young plaque. And so here's an example of somebody with a target we were not aware of, who just at 46 had a pretty high calcium score. And this is one lesion, and 2 years later, he had a new lesion. So we adjusted our therapy. Now, the old lesion getting bigger and causing an increase in the calcium score does not mean you're worse. Only new lesions are a problem. Now, very important in the clinical treatment is what was the concept popularized by my colleague, Dr. Khurram Nasser, the power of zero. And this is so important because I don't care what your cholesterol or risk factors are. If you have if you have a zero calcium score, you have a good prognosis. And this is an interesting study of people who presented to the emergency rooms with either soft plaque on a CT angiogram, but a zero calcium score, or just a zero calcium score and no other plaque. And there was no difference in survival over 8 years plus. And the reason is because if you don't have a big plaque burden, even if you rupture a plaque, the thrombus is going to be washed away. It's not going to cause an event. And the other important point is once you have a zero calcium score, we hear about people on low carb diets who have a pretty high LDL cholesterol, and should you give them a statin? Well, if you have a zero score, there's no benefit to statins. If you have a score greater than 1, there can be a benefit. But so if you have a zero score, you're at the very beginning of the game, and we like to follow every 5 years, but starting on a statin is not going to do anything. Now, here's an example of somebody who I have followed for over 20 years, about 25 years, who is diabetic, not very compliant with lifestyle. He had relatively high triglycerides, relatively low HDL. He has visceral fat. Here's liver, spleen, and this visceral fat. He has small LDL particles, and what you see here is this Kraft test. His beta cells are not generating a lot of insulin, and it's very, very delayed, which is why he's walking around hungry all the time. He can't access his fat stores or even his carbohydrate stores with this level of insulin. But for years, he's had a zero calcium score. He shouldn't. He's hypertensive also. He has small LDL. Something's protecting him. I don't know what, but our group led by Dr. Nasser has done the study. If you have diabetics and you have a lower zero calcium score, your prognosis is much better. By the way, he recently has developed one small plaque. But for years, we followed him with zero minimal scores. Now, why is small, dense LDL so important? Well, in most Americans now, even young, healthy males, they are producing too much insulin. The insulin is turning sugar and bad carbs into fat in our liver. We're overpacking large LDL particles that are misshapen. They're very slowly metabolized, unlike normally shaped small LDL. It's metabolized to large LDL, and that does not cause atherosclerosis. But the slowly metabolized does. So what's going on here? What causes lipoproteins to invade vessel walls to create the atherogenic plaque burden? And this is a concept really initiated and popularized by Dr. Ron Krauss called particle residence time. And it turns out if your lipoprotein particles are spending a long time in your bloodstream, they're getting oxidized, whether they're small, medium, or large, and whether they're LDL or HDL. And this is the way it works. Normal LDL goes, it's cleared from the bloodstream by receptors in your liver, and From there, it's taken into the liver, and it gets excreted through the small intestine. What about if you have a lot of small particles? They don't fit. They kind of knock around here, and eventually they're in the bloodstream, and they get oxidized, represented by the ring around. It's like putting Velcro around the ball and throwing it at a Velcro target, and it sticks. The oxidized particles you can think of as sticking to the endothelium. So once you have a lot of oxidized small LDL, and here's cross-section of a vessel, LDL, endothelium, cholesterol pimple, smooth muscle, and here's LDL, but we know they can be from small to large, usually a mix. And it turns out the small LDL is getting oxidized. So when it's circulating around, it sticks to the endothelium. And when it sticks to the endothelium, it goes under and it becomes part of the cholesterol pimple. What about normal large LDL particles that are getting cleared efficiently? They don't stick. They bounce off. And this is why people with very high LDL cholesterols, but in large particles, can have cholesterols over 300 and squeaky clean vessels. And what we've learned relatively recently, this is one of the best studies, the Quebec Cardiovascular Study, also found in the ARIC study, in the Jupiter study, and the MESA study, was if you look at tertiles of the amount of small LDL and risk of a coronary event, the more small LDL, the higher risk of an event. And it goes down with less. When we're looking at large LDL, it doesn't move the needle. Large LDL does not increase your chance of having an event, except in particularly some special circumstances we'll talk about. But for the majority of us, the high, large LDL is not a risk factor. And what we know now is that saturated fat in dairy, even in red meat, increases your large LDL significantly, but does not increase your small LDL. And that's why saturated fat is not dangerous to our lipids. What we know now is total cholesterol in the days of Ansel Keys was a very rough surrogate for total LDL, which was a rough surrogate for LDL particle number, which was a surrogate for small LDL. And now that we can measure small LDL, we really understand where we went wrong for so many years. Now, there can be abnormal receptor function on our liver that can affect, it's not nearly as common as the abnormal size of lipoprotein particles, but what about familial hypercholesterolemia? They got, Brown and Goldstein got the Nobel Prize for realizing that there were only half the number of receptors. So even normal size LDL couldn't be cleared efficiently. So what happened? They became oxidized, just like the small LDL, because they were hanging around in the bloodstream longer. And if they were hanging around longer, that means even the large LDL were getting oxidized. So instead of bouncing off, they stuck to the endothelium and ended up, again, building up plaque. So this is why patients with familial hypercholesterolemia, if they really don't have enough receptors, can have premature atherosclerosis. And unfortunately, there's not a good genetic test for measuring the receptors. What you do is you look at coronary calcium. So here's a patient I've followed for over 20 years. Total cholesterol is over 300, LDL over 300, this is close to 400. Large particles, but severe atherosclerosis, close to 2,000 when he was still in his 50s, 2,000 calcium score. And now here is a 68-year-old female who, by all our parameters, looks great. Perfectly normal belly, no obesity, completely normal Kraft test, no visceral fat at all, very large particles, and very high HDL. Why does she have coronary calcium? Well, it turns out she has what we call an HDL bump. Her HDL is not being cleared by SRB1 receptors in her liver. So they're accumulating, they're staying in the bloodstream, they're getting oxidized and causing atherosclerosis despite all her conventional risk factors looking pristine. Now, here's somebody with total cholesterol over 300, LDL well over 200, large particles, just like my familial hypercholesterolemia patient. She happens to be overweight, although her body shape rating is actually good, but a 0 calcium score in her mid-60s. So obviously her problem is not with her liver receptors. She has high enough cholesterol to be diagnosed as FH, but the calcium tells us the difference between this patient and the one I showed who also has a horrible family history of coronary disease. This patient does not. Now, coming back to what we call pre-diabetes. Why do we see calcium and liver problems for years before somebody's blood sugars are abnormal? Well, here's this overloaded VLDL particle. And this is associated with high triglycerides, low HDL. Here is fasting plasma glucose, and here is insulin levels. And so the high triglycerides, low HDL problems from the liver being overloaded with fat occurs way back here. And here, the pancreas is still normal, but like the liver, the pancreas is starting to fill up with fat. And what the fat is doing is it's decreasing the ability of the beta cells to produce insulin. And this is where the fasting blood sugar goes up. And because the beta cell and the pancreas is failing. But the high triglycerides, low HDL, small particles are starting back here, and you can be exposed for this 20, 30 years before your blood sugars are abnormal, your A1Cs are abnormal. And we are seeing this including fatty liver, including coronary calcium, including other problems. This is what we call pre-diabetes. And we know that if we look at A1C and the natural history of the postprandial insulin levels, they start going up when the A1C is completely normal. If we look at triglycerides over HDL, they start going up when the A1C is completely normal. They peak before somebody's diagnosed with diabetes. They actually go down when the pancreas is failing. But out here, it goes up again. The reason is your visceral fat is hypertrophying and the cytoskeleton gets damaged, you have inflammation, you release fatty acids, and that's when triglycerides go up and liver function deteriorates. And so that's why ALT starts going up way back here, goes down, and again goes up when you're having a problem with hypertrophied visceral fat. So evaluation of cardiac risk. What we find is, depending when somebody became insulin resistant, they will have plaque before they reach this threshold of abnormal glucose tolerance or hemoglobin A1C. It often depends on having these primarily non-lifestyle genetic factors at all as well. And the combination is very common. So here is a patient, pre-diabetic, 54, TOFI. He's very thin on the outside, but fat on the inside. And he does have high triglycerides, low HDL. His belly, not so impressive. His A1C only 5.4, but a very abnormal Kraft test. And we knew he was in trouble. We also knew, because he had fat in his liver, he had visceral fat, and he makes very small LDL particles. His very small LDL are at the peak, and small and very few large. And that's why he has a calcium score of 500, and he's had this for a long, long time. So here we can tell how long he's been exposed to the risk factors while we're evaluating other risk factors. Now, here is a recent young patient, 37 years old, already with coronary calcium. And he's got a belly, he has visceral fat, and he already has an abnormal Kraft test, even though his A1C is 4.6. So why does he have coronary calcium already? Well, he has an elevated Lp(a) of 181 along with abnormal insulin. It's high and it's peaking late. And here's his coronary calcium. And so we knew the treatment, we could start him on a statin, but he wanted to do lifestyle. And in fact, this was actually December, so this is over 8 months, he lost his belly, what we call his body shape rating improved. Here's his improved belly. And here are his LDL size distribution. And this was December. So this is where he started last April. And, some big particles, but small particles. And here, with a 30-pound weight loss, he's shifted his spectrum. His large particles are the peak by far. And if we look at his small particles, his small, and this is without statins, without any medication, went from 255 to 181. His medium particles also came down dramatically. And when we look at his conventional numbers, again from April to December of this past year, his triglycerides came down dramatically, as we expect with a low-carb diet, intermittent fasting. His HDL went up dramatically. And really, his LDL particle number decreased. His small LDL decreased. His medium LDL decreased. His A1C decreased. his ALT decreased, improved liver function. The one thing that went in the opposite direction, you guessed it, his LDL. And we showed he has bigger LDL particles. The bigger LDL particles don't get into vessel walls, and this is not dangerous. So a very instructive case from this year. Now, quickly, just another type of patient who is not pre-diabetic. A 56-year-old with calcium score at 56 of greater than 2,000, loaded with plaque, family history of coronary disease. Kraft test, not too bad, a little visceral fat, but not much. But what he has is what we call this LDL bump. Again, he's not clearing his, HDL bump. He's not clearing his HDL from the bloodstream, not enough SRB1 receptors from his liver, on his liver, and so the big LDL particles are hanging around, getting oxidized, causing that atherosclerosis. That plus an Lp(a) of 228 is why he has a problem. We are trying some medications. In this case, we chopped off a bit of his bump by using a medication that upregulates SRB1 receptors on the liver. And some of that is promising. But his problem was, despite not having a big lifestyle problem, he's homozygous for 9p21. So he has a problem with a porous endothelium. He has HDL dysfunction and very high Lp(a). Again, Lp(a) does not get oxidized efficiently. That's why it's atherogenic, particularly when it's associated with other risk factors. So he had high 9p21, high Lp(a), HDL dysfunction, although no important lifestyle problems. Thank you very much.